واضح الصوت.
طيب، بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. أسعد الله مساكم جميعا، ومرحبا بالحضور الكرام معنا اليوم. كما نسأل الله في هذه الليالي الفضيلة أن يتقبل منا ومنكم صالح الأعمال، وأن يجعل ما نقدم شاهد لنا بإذن الله.
آمين.
المقدمين والحضور إن شاء الله. معكم هذا اللقاء إن شاء الله NICU staff at the National Guard Hospital with experience working in pharmaceutical industry. باسم جميع فريق سعودي إيديو بلات، نرحب بالدكتور عبد الله الغامدي مقدم هذه المحاضرة ومؤسس منصتنا التطوعية سعودي إيديو بلات. طبعا دكتور عبد الله غني عن التعريف. دكتور عبد الله he is a board certified family physician from Canada. طب الألمان as well. Consultant and AG assistant. Professor of Family Medicine at King Abdulaziz Medical City in Riyadh and King Saud bin Abdulaziz University for Health Sciences. عضو في التواصلات الصحية والتدريبين. دكتور عبد الله أهلا وسهلا فيك اليوم. It's my pleasure. اليوم الكل عارف العنوان on tricky refills during COVID-19 pandemic. وعلى الخصوص ليريكا وبعض المنومات، بعض أهم المنومات. بنتكلم عن إن شاء الله تكون محاضرتنا ثرية ومفيدة للجميع. الآن أترك لك المايك دكتور عبد الله، فلتتفضل.
شكرا جزيلا أختي منال، ومساكم الله جميعا بالخير. Thank you for organizing this webinar, and truly honored to be with you tonight. نسأل الله سبحانه وتعالى أنه يوفقنا في هذه الليلة الفضيلة. Can't find the word really to thank our colleagues in the Saudi Edu Plat for their continued work which is voluntary work actually. We do this just for volunteering to organize these webinars, and we're going to have lots of webinars inshallah after Eid. Today we have a very important subject that we are going to talk about. What I want just to say, like a few housekeeping before we go. Ms. Manal will interact with the audience in terms of looking at their questions and probably stopping me at the middle of the webinar or at any time so that I can answer your questions. And I want to just say something, that this kind of webinar, if there is anything that happens to the connection, make sure that you have your own network working well. But don't worry, if there is any problem with the connection, we have some tools within the webinar that we can take you to another room and we will continue our webinar without having any problems. So don't leave the room. Some people ask about attendance certificates. Yes, we do have attendance certificates, and I'll share the link with you before the end of the webinar so that you can go to that link and just put few things and submit it, and you will receive your certificate of attendance automatically in your email. With that, I'm going to just start with you the presentation. Just a second, I'm trying to share my presentation with you. Do you see the presentation?
لا دكتور، إلى الآن ما ظهرت البرزنتيشن.
Okay. Do you see it now?
الآن بدأت تظهر، الآن على الشاشة.
Okay. Do you see the presentation clearly? Okay, fantastic.
دكتور.
Okay, great. So before we start the presentation, what I'm going to do is just I'm gonna write a pull over here, and I'm gonna just ask you a question. Do you prescribe So can you just look at the question? Do you prescribe Lyrica? I just see how many people they do. Okay. I'm gonna add another question over here. Sounds that we have almost 60% of people, they do prescribe Lyrica out of the attendance. Yeah. So it's about 63%. They prescribe Lyrica. I'm going to just add another question. The next question is, do you think Lyrica is addictive? Let me just put it as highly addictive. Okay, that's the next question. Do you think Lyrica is highly addictive? All right. Fantastic. So it's almost like 60% of people, they think Lyrica is highly addictive. Let's see that. So I'm going to start my presentation. I hope you all see it. So initially, I'm going to just give this disclaimer. I have no conflict of interest whatsoever. And this presentation is not representative in any way of my workplaces in National Guard or King Saud University of Health Sciences. And it's not intended to replace your existing practices and policies and procedures. It's rather actually going to give you an insight about these medicines and their refills during the pandemic of COVID-19. And probably you might reflect on the existing practice in your place or even outside, just to try to bring about the best guidelines that you can implement in your practice. But again, this depends on your own context. It depends on how the refill of medication clinics run in your place. And the objectives of this presentation is to understand the mechanism of actions of these important drugs, list their indications, appreciate their addiction potential, recognize patients at risk of becoming addicted to them, and discuss the existing practices in refilling these medicines for the patient of COVID-19 pandemic. Does that sound fair to you? I mean, is it clear? Does that sound fair to you about these objectives? Okay. Do you hear the voice well? All right, so the first medication that we're going to talk about is Pregabalin, and we call it Lyrica. This is the trade name. I think many people are familiar with it. I want to talk about its pharmacology. I know that many of you are actually pharmacists who are attending. The Lyrica is analog of gamma butyric amino acid, and which is the gamma aminobutyric acid is one of the neurotransmitters that work on the GABA receptor, and it produces CNS depression. I mean, that's what is the but interestingly, it doesn't work on it. It works on something called voltage-gated calcium channels, and specifically the alpha-2 delta subunit. And interestingly, this subunit, it allows the influx of calcium in the neurons, and it becomes excitatory, and that's why it causes pain, and that's why even in epilepsy, this is an explanation why epilepsy happens, is because of the overexcitation. And the same thing with the central nervous pain, or the central pain. So what does medicine Lyrica does is just it blocks this channel so that calcium will not influx inside the neurons, and this will not cause pain. And at the same time, also it will control epilepsy. And it's one of the adjunct medications for partial epilepsy, especially in adults. What made this drug special is its linear absorption. It does not go through the first pass effect, which means that it is immediately readily in the blood circulation. It's almost 98%. It's not protein bound, and it is not metabolized, and it's secreted as it is, almost as it is, in the urine. So this was exciting for many people, whether pharmacologists, clinical scientists, and even clinicians. And that's why the Pregabalin and its brother, the Gabapentin, were even in the black market for quite a long time. People, they thought it's just quite safe because it's not metabolized, it does not interact with other drugs, and it's just, they thought it's very safe. It reached the plasma concentration anywhere between 0.7 to 1.3 hours. And so you can see how effective when it comes to its pharmacokinetics. The half-life is about 6 hours, and the steady state is reached within 1 to 2 days. And probably these characteristics may make some of the people think that Pregabalin is highly addictive, and you could see the result in the polls. The trial doses of Pregabalin, and I want to just say that it comes in various doses actually. It starts from 20 to 600. But it comes in various, but the trial doses for the FDA indication of Lyrica, it's 150 milligram or 300 or 600. If you see lower doses than that, it's not the FDA indication, or that we are dealing with a different situation that is what we call off-label. Definitely it comes in 3 formats. It comes in capsules, in a solution, and it comes in tablets. I hope that the pharmacology of Pregabalin is clear, and the indications and clinical uses. Now, almost these are the FDA indication of Pregabalin. It's indicated for painful diabetic neuropathy, for post-herpetic neuralgia, low back pain with radiculopathy, central pain due to spinal cord injury. And you've seen a lecture by Dr. Faisal Al-Hudayfi the other day, and I asked actually that to have a comment on this one, but the lecture was so extensive and very full of rich information. And probably next time we're going to talk about the central pain due to spinal cord injury and work with our colleagues in rehabilitation and occupational therapy with that. Of course, it is indicated as adjuvant therapy in adults with partial epilepsy. It's indicated for anxiety and fibromyalgia. The commonest, really, two indications are actually painful diabetic neuropathy and post-herpetic neuralgia, in addition to treatment of partial epilepsy. Most of other indications are truly off-label. What about the clinical efficacy? When it comes to neuropathic pain, it's really highly effective. If you look at the diabetic peripheral neuropathy and the post-herpetic neuralgia, this is a systematic review by Paulson in 2016, and it shows that the number needed to treat in diabetic peripheral neuropathy is anywhere between 3.4 to 4.2, whereas in post-herpetic neuralgia is 3.4 to 5.6. Of course, it has various efficacy reports about low back pain with neuropathic pain, and epilepsy and anxiety and fibromyalgia. But you see lots of conflicting evidence around that. But the upper two conditions, or the top two conditions, which is the painful diabetic neuropathy and the post-herpetic neuralgia, its efficacy has been proven. What about the common side effects? Because, I mean, you can imagine it, any drug that works in the central nervous system, even if you don't know it, if you know that it works in the central nervous system, you can imagine some of the common side effects of this medication. Somnolence, ataxia, weight gain, dizziness, dry mouth, peripheral edema. These are very, very common side effects, and Verma and colleague in 2014 nicely reviewed these common side effects of Pregabalin. I'm putting here the contraindications: hypersensitivity and breastfeeding. Hypersensitivity is for sure. And this is where we are actually, the common side effects. And as we have seen, common side effects include somnolence, ataxia, weight gain, dizziness, and dry mouth, and peripheral edema. This is a nice review by Verma in 2014. The contraindications are hypersensitivity and breastfeeding. What about the addiction potential? Do you see it at least, Manal, do you see it at least clear to them here, if I do it this way?
For me, doctor, it's clear. We can.
What about the audience? Is it clear for you?
Audience. According to them, yes, it's good now.
Yeah, okay. So the addiction potential for the Pregabalin, in fact, always remember, like when a patient calls you in to refill a medication, the addiction potential is, you have to remember that patients who are actually getting addicted to Pregabalin, they do have underlying risk for getting addicted to Pregabalin, and especially those people who are using opioids. And that's why I'm telling you the FDA indication for the medication, because if you find that a person using a drug which is any one of those drugs, according to the FDA indication, yet the person becomes addicted to it, that's different than when the drug is being used for off-label indication and the patient becomes addicted to it. For example, if Lyrica is being prescribed to the patient for anxiety, and the person becomes addicted, in this case, we have to really assess the addiction potential in that sense, which is the fact that the patient has taken it for non-FDA indication. So when the review was done by Bonnet and Sherbom, this is one of the best reviews about addiction potential of Pregabalin. There is no convincing evidence about how powerful the Pregabalin is addictive. And that's why I asked you in the beginning whether Pregabalin is highly addictive. And the vast majority of you, they said it's highly addictive. Now, I'm not saying that we should change the status of Pregabalin as a controlled drug, but we don't have any evidence that it is truly highly addictive. The addiction that happens to Pregabalin was basically because of that many people who have used it were having underlying substance use disorder, and that's why they used it. In fact, you can look at patients who are using opioids and they are on maintenance therapy, whether it is methadone or buprenorphine, they tend to abuse opioids and also other drugs that we're going to talk about later on. And in fact, when the people take it for the indication, it does have very limited rewarding properties. I see colleagues like around me, and some of them actually not necessarily working in the same hospital. They're asking me, doctor, I mean, pregabalin is highly addictive. And the thing is that most of the people they use pregabalin, they are elderly, they are staying at home, and who comes to the clinic for the refill or call the clinic for the refill is the caregiver. And this raises the suspicion that pregabalin might be diverted somewhere or being abused by someone other than patient. And I agree that there is difficulty to confirm this, but when we talk about the drug itself, it's not really highly addictive when you give it for the indication, and specifically when you give it for diabetic peripheral neuropathy or you give it to patients with post-herpetic neuralgia. I'm going to stop here. Any questions so far about this? Any questions? If there is no question, then we can move forward.
If there is any question for Dr. Abdullah, you can ask now.
Any questions before we go to
I think there is.
Okay. So we're going to move to the clinical case here.
Okay.
And so this is the scenario. I hope it is clear for all. The scenario is a 72-year-old female. She has type 2 diabetes, peripheral diabetic neuropathy, hypertension, heart failure with reduced ejection fraction, asthma, and depression. She's taking Lyrica 75 milligram per day consistently since 2013. She tried to stop it during the COVID-19. Her asthma and depression acted out, and she started to have poor sleep. The patient resumed it, but she was running out of it, and now she's calling you to refill it. What would you do? I'm gonna just go back to the screen, and I'll put a pull over here, and I'll ask you how many of you will refill it as it is. Refill as it is. I want to just put a pull over here so you can interact with that. How many of you would refill the pregabalin as it is? Do you see the pull over here? Okay. So we're having 50-50. Some say yes, some say no. The people who are saying no is no. Yeah, they're 50-50. Safe answer.
There is people asking, what do you mean as it is?
The same
So
dose.
can you explain
Are
one more
you
time?
going? Yeah, Dr. Bara, same dose, same, yeah, the same dose. Are you going to just refill it as it is with the same dose? So you can see that at least 53% of people say that they are going to refill the medicine as it is, and 46% they would say no. And Dr. Bara also, she's saying, no, I'm not going to refill it as it is. Now, what will happen to the patient? Like, I mean, the patient is taking it like as it is, like 75 milligram per day since 2013. She has high risks. Yes, the slides are not moving. I'm just fixing this one on the clinical scenario. The patient is taking it for a very long time. It's almost 7 years. And now if we stop it, her asthma will act out in depression, and she might come to the hospital risking herself to COVID-19. So are we going to just give her the same dose and just to continue and see what will happen? We're not moving the slides because we are just on the case. We are explaining the case. So it is actually your call here. The 75 milligram, it's not for diabetic peripheral neuropathy. This is not the clinical trial dose for the peripheral diabetic neuropathy. Usually the dose is about 300 milligram per day, maybe higher, but this is the usual clinical trial dose. Probably this patient is taking it because of, I think it because of sleep. And quite often you'll find patients being put on Lyrica, whatever dose, and usually 75 milligram per day. And the common thing that you will not find is truly what was the indication. It's not documented. I mean, what was the indication? What was the target dose that the physician wants to reach? And what was the expectation, whether from the patient side or from the physician side? And that's what makes it tricky even. Far more trickier is the fact that you will not know who initiated this medicine. So it will come just, you are caught in the middle. You find yourself refilling this medicine and you don't know what's going to happen to the patient. Now, I don't think there is a problem to refill it in this case scenario, provided that there is a close follow-up to the patient, reviewing the chart and making sure that it is really indicated for such, and you have actually ensured that the patient will have close follow-up for other medical conditions, particularly asthma, depression, and the heart failure with reduced ejection fraction. And remember, it can be very confusing because Lyrica can cause peripheral edema. So some people, if they are off of it and they go back on it, they think that their heart failure has worsened. And this is not the case. You'll have to judge this in the view of other symptoms. So again, this is difficult to judge, but in this case scenario, if you think the patient is safe to be on it and you have a way to monitor the patient during the COVID-19 and ensure that the patient has access to other specialties, then it may be safe to refill it. I agree with you that this is not the dose for anything. If she is taking it for sleep, it can, because in this dose, Lyrica is good for restorative sleep. I mean, it acts on the phase 3 of 3 to 4, or you call the slow wave of sleep, and that's where the restorative sleep takes place, so it's good for that. I'm not encouraging to prescribe those for sleep, because this is, again, where a potential of abuse can happen and a potential of addiction can happen. So I'm gonna move forward with the slides, and we will move to the second drug, which is the Gabapentin. I'm gonna ask you a question. I'm gonna just put a poll again and ask you this question. Do you see the slide? Do you see the slide on Gabapentin?
Yes, doctor, we can see the slide.
So, do you prescribe Gabapentin? I'm gonna just see how many people still prescribe this medicine. I'm posting this question to you. Do you prescribe Gabapentin? Interesting. I'm not really surprised of the results so far. Okay. Okay. So Dr. Abra says she's not initiating it. So again, the vast majority of people, 65%, they say they don't prescribe it. Now, this is not surprising to me. If you look into the gabapentinoids when they have started, and especially if you look at the last 20 years, like let's say from 2000 to 2000 to 2020. Between 2000 2010, Gabapentin was there. I mean, it was the one that we prescribed for, especially the diabetic peripheral neuropathy. And then after 2010, its brother, the Pregabalin, was taking the lead, probably until today. But Gabapentin is more even in the black market, being abused, especially with people who have other substance use problems, and specifically opioids, and people who are taking methadone, and are taking maintenance medications like buprenorphine. They usually use this medicine to obtain the high. So currently, it's not being used as such, and I'm not surprised to see the results. So the pharmacology of gabapentin, it is again structurally related to gamma aminobutyric acid. But again, like the pregabalin, it works on voltage-gated calcium channels, specifically at the alpha-2 D subunit. And again, what does it do is it prevents the influx of calcium into the neurons, and it inhibits the excitation at the presynapse. And that's why it's good, or that's why it was actually invented to control epilepsy, partial epilepsy in adults. And now it's, it was used also to control the central pain. What is different from pregabalin, you remember that pregabalin has a quick absorption. This one has slow absorption. Now, both of them are related to food. And the peak plasma level is 3 to 4 hours, whereas you can see in pregabalin like 0.7 to 1.3 hours. The interesting thing here is that, and that's probably why not many of you still prescribe it, that can be explained pharmacologically. Pregabalin, you have a dose-response linear relationship, and I mean the plasma concentration linear relationship. The gabapentin itself doesn't do that. The more you increase the dose, it doesn't mean that the plasma concentration will increase. And that's why it's frustrating. You see, many doctors are prescribing, increasing the dose, and the patients will come back and they say that we're not really improving. And then people might start to suspect that they might be addicted to gabapentin because I'm increasing the dose and the patient is not responding. Well, this is one of the explanations. In fact, probably the most important explanation is that the higher the dose doesn't mean the higher the plasma concentration of the medication, and therefore you can relate it to the effect. So that's very important to understand. Again, like pregabalin, it's not protein bound, it's almost not metabolized, and it doesn't have any drug interactions. Some people might argue that it does have drug interaction, and I think really if you look at the pharmacology of it, and even pregabalin, they have additive effects, meaning 1 + 1 = 2, but they are not interacting with each other because they are not metabolized by the cytochrome B450, specifically the 3A4. They're not metabolized by that. Many of the drugs actually are metabolized in that mitochondrial enzyme. So what about the indications? Again, I am putting to you the FDA indications and the off-label. The reason I'm saying that, if the addiction potential happens when it is for FDA-approved indication, then we can say, well, probably it has a strong addiction potential. But if it happens because of label use, then because you don't have that much accumulating evidence to support it, although you can find even systematic reviews about the off-label indications, but yet it's not being put as such in many guidelines and as such in organizations who are using gabapentin. The FDA-approved indications are post-herpetic neuralgia, adjunct therapy for partial seizures, and moderate to severe restless leg syndrome. These are the indications for gabapentin. However, even nowadays, I rarely see patients taking gabapentin. The off-label uses: fibromyalgia, bipolar disorders, essential tremor, depression, irritable bowel syndrome, alcohol withdrawal, migraine prophylaxis. But again, these off-label indications are actually probably within the local hospitals and services guidelines. Again, you might find patients who are calling you to refill the medicine for those indications, and you need to be cautious about that. You will have to go back and see the patient record, the indication, why it was prescribed, what was the initial intention, what was the initial outcome that the physician was targeting, and what were the expectations of the patient? Was it documented or not? Before you really refill the medicine for the patient. What about the clinical efficacy? Definitely, WIFN has done a fantastic systematic review on the clinical efficacy of gabapentin, and you can just see it's in 2017. Yet many people, and in fact, it's not just like it's not only you that the vast majority are not prescribing gabapentin. It's even outside; they're not prescribing it as such. And you can see that for diabetic peripheral neuropathy and post-herpetic neuralgia, you can see the wide range of dose, and this explains why the increase the dose and the plasma concentration doesn't increase, and so therefore the dose-response relationship is not linear like the pregabalin, and this explains this wide range of dose. It's 1,800 to 3,600 milligram to treat those patients with diabetic peripheral neuropathy and post-herpetic neuralgia. It is effective, and in this dose range, for these two conditions, the problem is you have more side effects, lots of side effects. And again, in 2018, the Narine and Adcock have done very good review, and they questioned the effectiveness in chronic low back pain, fibromyalgia, which we indicated previously as it is off-label indication, nerve injury, and mixed neuropathies. It's not as really good. What about the common side effects? Well, it does have lots of side effects, really. Deficits in visual field, myopathy, self-harm or suicidal behavior, mitochondrial toxicity, somnolence, dizziness, diarrhea. This is done by Quintero in 2017 as a systematic review too. But it's quite interesting even that you see the anecdotal reports about suicidal behaviors among those who abuse it in the streets. And commonly that they abuse it, those who abuse opioids and cocaine, they are keeping to take like higher and higher doses, and probably the self-harm and suicidal behavior would be seen beyond the 1,800 milligram a day, and not surprisingly even to see it higher and higher above the 3,600 milligram. And this is not simply that it's the dose response. No, it's because of the side effects here, and they are taking many other drugs and other substances, so the additive effect may result in a self-harm or even successful suicide. So this, you keep it in mind. Contraindication, myasthenia gravis, it does actually interact with the receptors, and plus it interacts actually with the myasthenia gravis medication, not the medication itself, but the site of action, and it can actually worsen it. And of course, it can also worsen myoclonus. So it is contraindicated in these two conditions. What about addiction potential? In general population, I gotta just tell you something about addiction potential of any prescribed drug. If you say it is between 1 to 19%, you're safe. Go to the literature and look at it. You'll find that the majority of people just put it in this, I don't know why. I don't know why this figure, 1 to 19%. Quintero again did a very nice review on this, and it actually shows in general population that it is 1.1 to 19%, and the lifetime risk for those people who might use gabapentin, the lifetime risk of addiction is 1.1%. Having said that, any questions so far before we go to the clinical scenario?
Yes, doctor, I believe there's questions. One from Dr. Hala. She said, if I want to stop, is the patient able to do so?
If you want to stop?
I think to stop prescribing the gabapentin.
Yeah. Well, stopping those medications, usually whether it is pregabalin or gabapentin, it has to be gradual, and usually it takes about 1 week to stop the medicine. Now, this is easy said than done. Many patients who use gabapentin or they use the pregabalin, they use it for a very long time, and they have coexisting conditions like especially anxiety, and they are taking other medicines, and this complicates the gradual withdrawal of the medicines. But you don't stop it all of a sudden. You have to do it gradual. You have to make sure that the environment is safe for the patient to do it. I find it very difficult to do it over the phone, although you might find online some services that they help those patients to stop the medicines virtually. I don't really encourage this. It's dangerous. Again, it's your call, and you have really to consult with other experts. If you're not expert in handling those patients who are addicted to these drugs, or they are having not just only addicted, but they want to stop it, but they cannot because of re-emergence of their symptoms like pain, anxiety, and poor sleep, and also aggravation of the underlying conditions, you need to consult with them. This has to be done calculated, and it has to be done in a controlled situation. It has to be individualized. I hope this answer is clear. Any other questions, Manal?
There is another question from Fathiya Asiri. Who's the patient that really need the Gabapentin? Because since 2018, it's become like trending, all doctors prescribe it.
Very interestingly, I have two questions actually, Fathiya and Basma. Fathiya, the two indications for the gabapentin, we've discussed that. I personally would say for the peripheral diabetic neuropathy and the post-herpetic neuralgia. Of course, some people, they prescribe it also for the restless leg syndrome, and these are the FDA indications. If you want to know the indication of the medicines, you have to look the FDA indication. Go back and review the FDA indication. Many of the gabapentin prescriptions nowadays, we see them off-label. And the people, they think it's because it works on chronic peripheral neuropathies, then they think it's okay to prescribe it in any neuropathy pain. There is no convincing evidence for many of the neuropathies that gabapentin is being prescribed for. It's basically for the diabetic, and especially the painful diabetic neuropathy, and for the post-herpetic neuralgia. Interestingly, is it like, increasing? I don't know about your experience really in 2018. What I see is a steadily decrease of the use of gabapentin as prescription, but I see it probably the same level of abuse in the black market by drug abusers and people who are using other substances. Basma has a question also, are the online services local? No, they are not local. I don't know of any local services that provide the withdrawal or like tapering of medicines like gabapentin or the benzodiazepines or other sleeping medications that we're going to talk about. I don't know of any. But in the West, yes. I had come across several people whom I know personally that they are trying to provide this online. We will see post-COVID-19 what will happen, whether they're going to allow for such online services, because to be honest with you, there are lots of issues, privacy issues, medical, legal, and ethical issues about doing the withdrawal of these medicines virtually. Those patients require probably face-to-face support in a controlled environment, and they need a lot of privacy to do it. I'm not saying that this will not happen, but I think it's going to be challenging to do that. I have a question from Mohammed Al-Babtain. Do you see it, Dr. Manal, also? Do you think gabapentin should be controlled as pregabalin? Very interesting question. The gabapentin is already in the black market being abused. Until we have enough data of Muhammad like pregabalin, at least, then it's difficult to give this answer. But I can refer you that the Canadian Medical Journal, Canadian Medical Association Journal, they have published very interesting article last summer. You can access it for free, which talks about the potential of gabapentin. Now the drums actually are being beaten just to ring the bells actually about the gabapentin and its potential abuse. I'm not going to be surprised, given its abuse in the black market, that it will become controlled as the pregabalin. But when I say controlled, it doesn't mean you get threatened. And we don't want to threaten the professionals who have the power to prescribe them, not to prescribe them. If you have a clear indication, then do it. Because until now in the literature, the abuse has happened because of label indications, that these medicines have been used for indications that are not FDA approved or not approved by the FDA locally. I hope that is also clear to you. Okay, we're going to go to the case about Pregabalin. Addiction potential. So we're going to go to, is the clinical scenario clear to you? Fantastic. Let's just look at this clinical scenario. You have a 65-year-old male. He has type 2 diabetes, hypertension, dyslipidemia, osteoarthritis of the knees, and hypothyroidism. He calls you to refill his gabapentin. He takes 1,800 milligram daily for his presumed diabetic neuropathy since May 2017. It's about 3 years now. His diabetes is well controlled in metformin and glycoside. His A1C is 7.2 since the diagnosis in 2005. He says he cannot sleep due to burning feet. When you review the chart, of course, you find that it's a history of 3 years, and you start flipping the chart. You're trying to find out who have started and what was the reason. Then you found in the chart that someone put burning soles, and because of that, he or she thought that this is the peripheral diabetic neuropathy, and then the gabapentin was initiated. So what are you going to do? I'm gonna put another pull here regarding the gabapentin. For this specific patient, are you going to refill it? So let me just put the ball. Are you going to refill it? Yes or no? So are you going to refill the gabapentin for this patient? I don't know what's wrong with the 50-50 pulls over here. Okay. Now, when you say no, try to think about what will happen to the patient, this patient, if you stop the 1,800 milligram, what will happen to him? Do you think he will land in the emergency asking for something, exposing himself to COVID-19? So I see many people say yes, yes. Allah says yes. Muhammad al-Baqir says yes. Yes, Dr. Abara, during COVID-19 pandemic, yes. I'm not sure that this is now changing pull over here. All right, so about 60% they say no, we are not going to refill it. I understand that I have Dr. Noor here says that if we don't refill it, it will cause emergency situation because we cannot stop such a big dose at once. Remember that when we said that if you want to stop it, it has to be gradual. Now there are few things to remember here: the age of the patient, the comorbidity of the patient, and there is a problem here. Does this patient really has peripheral diabetic neuropathy? So how many of you believe that he does have, given this history? And by the way, these are real clinical cases. I'm not telling you like from which organization, but I have encountered during my lifetime these kind of cases. Do you think this patient really has, what makes you comfortable to think that he has a peripheral diabetic neuropathy to keep him on this dose? Any answers in the chat? Do you think, how many of you just think that he has truly, from this description, truly peripheral diabetic neuropathy. Just write down yes or no from the description of the case. So Muhammad says no. Well, I think he doesn't have peripheral diabetic neuropathy. Fathiya says yes. Ahmed says no. No peripheral diabetic neuropathy. Dr. Maha, رحب يا دكتورة, she is saying no. So many people actually, they're saying no. And yeah, the reason it's no, because I can tell you one of the common traps that many physicians fall into is that when a patient has diabetes and they come complaining of burning soles of the feet, the people think that it's diabetic neuropathy. You'll have, well, peripheral diabetic neuropathy, but isn't like sucks. It's not like just only burning feet or burning soles of the feet. You have to confirm it. So many people, they just ask the patient, and if the patient says because he's diabetic or she's diabetic and they are having this burning soles, immediate reflexive prescription of Gabapentin or Pregabalin, thinking that they have peripheral diabetic neuropathy. That's not the case. You will have many people in the general population complaining of burning soles and they don't know the reason, and you will never know the reason why. Even if they have poorly controlled diabetes, you have to confirm it. Now, this case, that was the only documentation. The patient was put on this dose. And is it a placebo effect that he is able to sleep at night? Or is he like using some other drugs that make them sleep at night? Or because of the sedative effect or the depressive effects of this medication that he's sleeping on it? I think this is the reason. But again, it's a massive dose to stop it. The patient has been on it for a very long time, 3 years. I'm not going to stop it and then bring the patient to the emergency because of that. But I will keep a good follow-up with the patient. And I want to really see if I can have an access to the doctor who prescribed it. But I'm going to just tell you something, even in the refill clinics, most of the time you are caught in the middle. You're going to refill medicines that you have not started yourself. And everywhere, not just only in the kingdom, everywhere, you don't find guidelines for refill of medicines because the internal practice in the organization, they think, or like it's informally, that this is part of your practice. This is part, whether the patient is there or not there, you should be able to decide when to initiate this medicine, when to continue it, when not to continue it. And that's why we don't have guidelines. Or many places don't have guidelines. It's not a surprise. But the reason I'm bringing those medicines, because in the past, the patient could come to you. Like if I am giving the refill for, like, let's say 3 days, 4 days, a week, I know that the patient can come to me and sit with me in the office, and then we'll have the face-to-face interaction, and then we start to plan on doing something. But nowadays, God knows when this pandemic will stop. So if I am going to refill this medicine, what will happen is this. You will give like a month, like a prescription, and then another call for refill will go to another doctor. This doctor will come and see that you have refilled this medicine. He or she will refill it, and then the cycle will continue. And probably by the end of the pandemic, you find your patient taken a medicine for a very long time that is not indicated, at least, or to say the least. So again, this is your call. Personally, I would really make sure that if I can bring the patient to the clinic safely without risking him to COVID-19, I would do that. I would start actually tapering this medicine, because it is not convincing that this clinical scenario, the patient has a peripheral diabetic neuropathy. I have a question from Dr. Yahya. Welcome, Dr. Yahya. I think that diagnosis was not confirmed. That's true. And no assessment. With this good DM control, we should ask if there are symptoms of DPN. Definitely, I mean, you know, we have to find the documentation, because the patient is away from you. The patient is not close to you. Maybe in the future we will have some like, you know, wearables where we can diagnose this neuropathy from distance, like virtually. I don't know. It can happen. I don't know. But for this case, yes, it's not convincing that this patient has peripheral diabetic neuropathy, and therefore the patient is now continuing on a medicine that has high potential of interaction, especially at this age and given the comorbidities. So you can refill, but again, try to put a plan. That is a practical plan, depending on your context and situation, to really taper off this medicine and take it off, unless you confirm that the patient has peripheral diabetic neuropathy. Otherwise, I don't want really to continue this patient on this high dose for, like, God knows when this pandemic will be over. Okay, great. We're going to continue to the next topic, another interesting topic, which is talking about benzodiazepines. Again, I'm sorry, I'm going to just give you another pull over here about benzodiazepine. Reset a pull over here. I'm going to ask you this question, which is a general question. Do you prescribe benzodiazepines? I'm just putting abbreviations. I would say usually, okay? It's not like, you know, once in a blue moon, but I'm saying usually. So I'm gonna put the put right now, and let me see. Do you prescribe benzodiazepines usually? Very interesting. Okay. 90% say no, and 9% or 10% they say yes. I'm going to ask you a question. Do you see the slides clear? Like, are they clear for you? Fatih says, like, you know, actually that prescribed to me only to make me sleep, but I refused it. Okay. Folks, do you see the slides clear? I'm sorry that the screen here is not splitting because I have to monitor something else going with the webinar. So that's why it's, okay, good, fantastic. All right, so we're gonna talk about the pharmacology of benzodiazepines. You know, benzodiazepines, we take them in pharmacology. They work on the gamma butyric acid, GABA receptors, and especially GABA receptors A, specifically alpha 1 and alpha 2. If you can see down there, I put that alpha 1 is good for sedation and amnesia. It works, I mean, you know, if anything that works on this subunit, you know, the GABA has 5 subunits, but I'm going to focus on these 2. And the benzodiazepines that work on the alpha 2, this is for sleep regulation and anxiolysis. So most of the benzodiazepines, they work on these 2 units, but I want to warn you that they are not selective. The general benzodiazepine are not selective. And what they do to the GABA A channel is that it has what we call allosteric effect. It doesn't mean it affects it directly. No, it binds to these receptors and it makes this channel to open and close, and chloride will influx. And you know, the chloride is negatively charged, so it causes depression. It depresses the action potential, and that's why they are seen as depressant. So this is basically how it works. Now, this action, this pharmacological action, is determined by, because you have plenty of types of benzodiazepines, variable doses, variable routes, and variable lipophilicity. So I can just tell you briefly that when you deal with any kind of benzodiazepine, the trick part is, one, make sure that you are using it for the FDA indication. Second, make sure that you have assessed the patients really properly. And the third thing, make sure that you have a plan when to start and when to stop. Unfortunately, I'm sure that if I ask you this question, do you find any plan written for patients being prescribed benzodiazepines? You can just put it on the chat. Do you find the plan? Do you find like physicians commonly put why they have started benzodiazepine, for how long, for why, and for how long, and when they are anticipating to stop it? Do you find this is documented anywhere in the chart, anywhere in the process of care of the patient? Any answer from the audience? Do you find it documented? So Tura Mema says yes. Well, that's great. Now, if you look around the world, actually, I mean, it's not just, and you review the literature, quite often you see healthcare givers, they start the benzodiazepine. They have, in fact, they know the indication. They actually, they have it in their minds. Why they are starting it, probably they have it in their minds. When to stop the drug, they have it. The problem is that they don't document it. So not everything in the patient care is documented. And this is the problem. When you are caught in the refill clinics, that's what happens. You start prescribing a medicine that you haven't started. You're giving it to a patient whom you don't know who's going to re-prescribe the medicine after you, and for how long, and when this COVID-19 will end, and what will happen to the patient post-COVID-19 pandemic. Well, this patient becomes really dependent, at least dependent on benzodiazepine, chronic use of the benzodiazepine, and it becomes difficult to stop it. That is something you need to answer in your clinic. Fine. What about the indications? Again, I'm giving you the FDA and off-label. The FDA indication for benzodiazepine, anxiety, whether this is generalized anxiety disorder, panic disorders, social phobia, insomnia, anesthesia procedures, definitely, you can see that, seizures and status epilepticus. These are the FDA indications. The off-label indications: agitation, alcohol withdrawal, muscle spasm, sedation, restless leg syndrome, and sleepwalking disorders. This is very important, guys, to understand. So if you are called for a refill by any patient, remember this FDA indication, if it is indicated for those. If it is out of the label, be careful. And if you need help, consult people who have expertise working with those benzodiazepines. And I can just tell you something, whether it is from experience or you notice it or whatever, the majority of benzodiazepine prescriptions are issued by non-psychiatrists and non-addiction physicians. And that's fine. That's okay. You don't have to initiate them by psychiatrists and addiction physicians. But it just indicates to you that this is a very common practice in front lines. The people who commonly prescribe these medicines are actually general practitioners and emergency physicians. Now, emergency physicians, very common. A patient goes there, the patient is having any problem, like, deranged sleep for whatever reason, maybe like overreacting to something, maybe a problem at home, whatever. And then you find a prescription for a week or two of lorazepam. And then this continues. The patient goes from the emergency, goes home, and would call you 2 weeks later, say, doctor, I want just to refill my lorazepam, and I cannot come to the emergency, cannot come to the hospital because of COVID-19. So what are you going to do? Are you going to refill it? When you review the indication, the patient was just stressed out. Is benzodiazepine part of the stress management, or is stress one of the indications to give benzodiazepine? The answer is no. So again, I'm going to talk about the clinical efficacy. Definitely, it is more effective than SSRIs and SNRIs and generalized anxiety disorder. No doubt about that. But the problem is generalized anxiety disorder tend to be chronic. And if you look into the clinical trials and the use of benzodiazepine, most of the time it has been studied for 2 to 4 weeks, not more than that. So we don't know what's going to happen for a long time. And in fact, about a third of the patients, 40% of the patients taking benzodiazepine, they take it chronically. They take it for years. And then the time you realize that the patient, do you hear the voice? I see that Sumaya is saying like she doesn't hear anything. Do you hear the voice, Manal? Is my voice clear? Manal, is the voice clear? I'm just asking the audience, do you hear me? Okay, good, great. So, as I said, that chronic anxiety, generalized anxiety disorder, and tends to be, and even chronic insomnia, it tends to be chronic. It's chronic. And when you initiate benzodiazepine, you have to be very careful. If it is something if it is something that is for a short period of time, then this is like justifiable. But when you are managing a patient for very long, you have to be very careful. You have to assess your patient really, and you have, again, and I'm gonna say it again and again, you have to really put the expectation clear to you and to the patient, because you have to have a plan when to stop it. You cannot continue it forever, right? For panic attacks, you need to use high potency benzodiazepines like alprazolam, clonazepam, lorazepam. You can initiate them and then you taper, because for panic attack, again, the best treatment for insomnia and panic attacks is cognitive behavioral therapy, plus minus medication with that, but cognitive behavioral therapy, because this has a carryover effect, a positive carryover effect for a very long time. Benzodiazepines might be good in the initiation or the initial phase under controlled situation and certain criteria with your patient, but you cannot prescribe it for very long. Is it effective for insomnia? Definitely, it is effective in insomnia. But again, the tolerance, the addiction potential of benzodiazepine is there, and so you have to be careful when you initiate benzodiazepines in your clinic. What are the common side effects of the benzodiazepines? Again, as I told you from the beginning, if you are dealing with any medication that works centrally, you can basically imagine from your neurophysiology or from neuropharmacology, you can imagine really what are the side effects. So it's not really surprising to see that the common side effects like sedation and steadiness, impaired psychomotor speed and accuracy, and this becomes heightened with people who are older and they have other comorbid conditions. So be very careful. Cognitive impairment, and you've seen the debate about cognitive impairment nowadays. I got questions from people taking lorazepam, and the caregivers would ask me, is my dad or my mom at high risk of dementia? I'm sure you've been through that. I'm sure you've been getting questions like this. And it's very confusing, because if you look at the literature, at least from 2013 to 2000, or the end of 2019, they put almost like a convincing evidence that benzodiazepine would cause dementia. But if you look at the latest article published in the New England Journal of Medicine Watch in April, it shows that benzodiazepine actually may reduce the risk of dementia because they think that insomnia and anxiety increases the accumulation of the amyloid beta um, fibrils in the central nervous system, especially in the deeply seated structures. So it's insomnia and anxiety. It does increase the accumulation of amyloid, which is actually the pathological landmark of Alzheimer's dementia. So they think that if you give benzodiazepine, dementia risk subsides. And now they're bringing this. They say if the patient has dementia, don't prescribe benzodiazepine. If the patient doesn't have dementia, be very careful when you initiate it. Now, this is just their recommendations or like their conclusion, yet they're looking for further evidence as to what to do with the benzodiazepines in the elderly. But you can see that many people are avoiding it altogether in the elderly people. And I am on the side of caution, especially when you refill the medicine, because it's very tricky. And specifically with the benzodiazepines. Again, you will find that the patient has been for very long on it. Very commonly, you'll find them taking it intermittently, and the refills are actually intermittent. And in one side, it might indicate to you that, okay, the patient doesn't look like is being addicted to it. On the other side, it's worrisome because the patient condition changes over time, and you're not sure if you continue prescribing episodically the benzodiazepine, would you put the patient at risk of side effects or not? Again, it's a very tricky thing. So if you are not sure how to do that, or if you're not sure about the refill and how safe is the refill for the benzodiazepine, you can consult with your colleagues. But if it is clear cut case indication to put the patient on the benzodiazepine and you continue safely without risking the patient to come to the hospital and get exposed to COVID-19, you might as well do that. Of course, the precautions, as you can see down, it's the elderly, patients with lung, liver, or kidney dysfunction, definitely. This is very important. And patients taking other classes of medication, specifically any CNS depressants, any medicines that work centrally, you have to be very careful prescribing benzodiazepines along with them. All right. What about the addiction potential of benzodiazepines? Can you imagine, like in 2008, maybe you can link this in 2008 to the economic situation that happened, the economic crisis that happened. But in US, there was 75 million prescriptions of benzodiazepine. Of that, what we are interested in is to make sure that they are not prescribed for non-clinical use. In other words, you want to make sure that they are indicated. So this is interesting. You can see that the non-clinical use ranges from 2.3 to 18%. Do you remember when I told you in the beginning that if you say the addiction potential for these prescription drugs anywhere between 1 to 19%, you'll never be wrong? I don't know why. I have been with watching this for the last 20 years, and it is the same, really. Prescription drugs, their addiction potential between 1 to 19%. Then you pass the exam. Okay, what are the risk factors for addiction? Alcohol use. You see many people, if you are dealing with people who have alcohol use disorder, the vast majority have mild withdrawal symptoms, they self-treat with benzodiazepine. Comorbid psychiatric conditions. And definitely, it's one of the, they have problems with the sleep. They have problems with muscle tension, and they feel that they are on the edge. And that's why they use benzodiazepine just to have at least or think that they have some control of these symptoms. Dependence on opioids and other substances, very important. If you ask the patient has a history, whether it is documented or the patient is declaring it to you, they have a history of substance use, please do not prescribe benzodiazepine. They are at very high risk to get addicted to it or abuse it. Antisocial personality disorder, you can read about that and see how this is linked to dependence on benzodiazepine and alcohol too. Remember that alcohol actually increases the potential for antisocial behavior. Okay, Before we go to the clinical scenario, do you have any questions? Any questions regarding benzodiazepine? We're almost going to the last session after that, and then we close. Any questions for benzodiazepines? Sarama says that from my point of view, it's not good ideas of ER physicians and GBs to prescribe it without consulting and arranging follow-up appointments with a psychiatrist. The problem, Dr. Maha, when people have insomnia, if you tell them that you need to go to psychiatrist, the answer to you would be, we're not mentally ill to go. And so that's why they go to frontline doctors. And I don't see a problem for frontline doctors to prescribe it. But what I want to say that make sure that you know that you are clear about the indication, you know about the outcomes that you're after, and that the patient is clear about the outcome and what is expected. And then you ensure that there is a continuity of care for the patient. If you are sure of all of this, then it's fine. You cannot access psychiatrists all the time. You have a person with insomnia, or they are having stress for whatever reason. And again, you know, still the stigma of visiting a mental health professional is there. And not every patient will actually go and visit a psychiatrist for that. I hope this is clear so far. Now, we're gonna look at this scenario before we go to the last session. This is a clinical scenario. A 28-year-old male works as a banker. He works from home due to lockdown. He calls in to refill his sleeping pills given to him by the emergency doctor 3 months prior to the lockdown. He say his sleep is upside down. This makes him prone to conflict with his family. When you reviewed the medical record, you found 2 visits in total. I mean, he's not really a person who is visiting the doctor, the hospital, and he was given lorazepam 1 milligram for 1 month. Are you going to refill it? So I'm gonna ask you, I'm gonna just have another bull over here. Are you going to, I would say, refill or not? Are you going to refill the lorazepam for this young banker? Here is the poll. Okay. I want to just see you, the audience. Are you going to refill? So I'm getting no 100%. Okay. I think it's an overwhelming answer. They're saying no. Well, I agree with those people who say that, you know, we're not going to refill it. Actually, if you can arrange, like, you know, a visit for this patient to have like counseling, because what I'm really worried about is that he's having conflict at home, and you want to make sure that it is safe at home and not, you know, nowadays we have reports about abuse of children, abuse of elderly, and abuse of others at home. So I think it's very important that you make sure that there is no abuse, there is no risk for this person at home, and you make it clear that the benzodiazepine is not going to be the right option for him. In fact, there are many things you can show online for your patient. You can share with them what to do, because in this case, insomnia, his schedule is upside down because of the lockdown. He probably like, you know, the whole time 24 hours is for him. So if you just plan with him any kind of like cognitive behavioral therapy for this approach, if you think about stimulus control, if you send them any link or like YouTube just to show them what to do in this case, do exercise, have a sun exposure early, like, you know, in the morning, and this will help them a lot to restore the sleep. The lorazepam is not indicated actually for sleep. And this is common practice. You see many people prescribe lorazepam for sleep. I don't know why. It's not an FDA indication to give lorazepam. I'm not saying that this is a wrong practice, but I don't know why, because I've been looking into this. It's been there in our practice for quite long, for over 2 decades. Very common. People give lorazepam. You go to the emergency, give lorazepam. Even during the training, you have a resident, say, doctor, my patient, like for the last 3 days, she's not sleeping well because she's coming from whatever, or she's suffering a financial crisis, and she wants just something to sleep. Okay, give lorazepam, 1 milligram. Sounds fine. But truly, that's not. If you look at the indication, the medicines that are being used for sleep, I'm going to give you a slide in the end. This is very important slide. I want you to look at it. Lorazepam is not one of the FDA indication for insomnia. Can you just help me here? How many of you give lorazepam to insomnia? Let me just say, do you give lorazepam for insomnia? Can you just write yes or no on the chat? Do you prescribe lorazepam in your practice for insomnia? Fatih says no. We will share the link here. Anyone prescribes lorazepam for insomnia? Dr. Abra says seldom. I agree that, well, this is good. At least, at least that people, you know, if you just get today, you know that lorazepam, never give it for insomnia. It's not, plus it's intermediate action. I mean, it works for like anywhere between 6 to 24 hours. So it's gonna take the carryover effect. So many people might have a side effect like dizziness or like, you know, psychomotor problems, and they can be involved in accidents and all of that. So I don't really recommend to give the lorazepam for insomnia. Now, the last part of this webinar, we're going to talk about the Z drugs. And I'm going to just ask you like this question. And this is our last poll we're going to put here. I'm going to just ask you, do you prescribe Z drugs? I hope that many of you know the Z drugs, and those are the non-benzodiazepines. Those are invented to replace benzodiazepines. So do you prescribe the Z drugs? Let us see your answers. Yes, no, 50%. Okay. Oh, very interesting. Okay, very interesting. 83% they say no, they don't prescribe the Z drugs, and it's not surprising to me. And 16% say yes, or 17% say yes. Now, if I give these questions to physicians in early 2000, or between 2000 and 2010, they would probably have a reverse answer here. Maybe you'll have 8 out of 10 saying yes, we do. And I'll show you something here which will explain to you why the Z drugs started initially to be prescribed and then later on it's not. The pharmacology of the Z drugs, I hope the slides are clear to you. Again, like benzodiazepines, they act at the GABA A receptors, but they are more selective. And that was the reason for the ecstatic like feeling of the pharmacologists and the scientists back when they discovered those drugs. You know, they were very happy that they are very selective, and that the potential side effects and the tolerance and dependence and addiction and all of that will not be of problems in these drugs as compared to benzodiazepine. And definitely, like, Gunja has done a very nice review on these drugs, and it does reduce the sleep latency, so they are good for sleep onset, sleep maintenance, and some of them good for like restorative sleep, like those who have frequent awakening. They're really good. The onset of action is 30 minutes. Hey, and that's why they have reduced sleep latency. And the half-life is 1 to 7 hours. What else you want? But I'm gonna just share with you this table. This is important. These are the FDA indicated Z drugs. These are the FDA indicated Z drugs. Zolpidem, immediate release and extended release. Okay. And you can see that they are working all on the cytochrome P450, especially the 3A4, and that's pharmacologically means that it has a lot of interactions with many other drugs, lots of interactions. So be careful when you prescribe those Z drugs. And then cumulatively over time, physicians and scientists have discovered really the vast potential of side effects of these drugs. And that's why, for example, in UK, one of the nice guidelines, they're not using it anymore. They're going back to benzodiazepines and not using the Z drugs. In addition to their cost, they're more expensive than benzodiazepines. So again, the indication, they were indicated for insomnia. So the primary indication is insomnia, because they were invented to replace benzodiazepines and get over the addictive potential of benzodiazepines. So, and again, they are really good in insomnia, but they're not the first line unless other measures have failed. So you might use them, and again, you can use them for short-term and long-term insomnia. But you have to be careful, monitor your patients. You have to really individualize your patients that you want to stop prescribing Z drugs for them. What about clinical efficacy? When it comes to hypnotic efficacy, they're similar to benzodiazepine. But that was in 2000, and that's what I'm telling you. The cumulative literature was like, and they were ecstatic to people back in 2000. They say it's having, like, it's as effective as benzodiazepine, but with excellent safety profile. But look at 2012 by Hido, Medina and colleagues. They did very nice review on this. They find that it is insignificant effect on adults with insomnia compared to placebo. What has happened? Did we improve, like, were the initial trials not good enough to judge its clinical efficacy and safety profile? Or is it that the cumulative literature is showing something? Or I don't know, just you'll have to watch this. From 2000 to 2010, Z drugs were there, and nowadays they're not as such. And you might find them like different in different countries, like in Europe and North America, but they are not put as first line. I don't know why. And the documentation of side effects is even becoming more, and you'll see here about the common side effects. You can look at that. Cognitive impairment. Of course, the benzodiazepine and the Z drugs, they have this anterograde amnesia, which might be good for some people because they don't want to remember what happened during their sleep. But it does have significant cognitive impairment. One of the studies have shown, for example, zopiclone. If a patient is taking zopiclone and driving their cars, the effect of zopiclone is exactly the same effect of someone who has alcohol blood level of 0.8 milligram per deciliter. Can you imagine that? As if the person is drunk. It has, well-known profiles about falls and fractures. It causes sleep driving, and specifically with zolpidem. They get out of bed, they turn on the car engine, and then they sleep. They go driving while they're sleeping. Daytime fatigue, addiction, definitely, and increased mortality. Now, this is in 2012 also. That wasn't the case probably in early 2000 or even in the 90s. These side effects haven't been reported as such. And there has been recent concerns about dementia, infections, and pancreatitis and cancer. Now, the debate is continuous from 2017 until now. But these are real concerns that we have to keep in mind when we prescribe Z drugs for our patients. What about the addiction potential? Patients with history of substance use, underlying psychiatric conditions, please do not prescribe Z drugs or benzodiazepines to them. If that is being done, make sure that it's done by a specialist, addiction specialist, along with a psychiatrist, but not you as a frontline doctor or like a person who has the privilege to prescribe the medicine, but you're not specialized in addiction or in psychiatry. Okay, let's have the last clinical scenario. Look at the scenario. A 56-year-old female has major depressive disorder, has obesity and hypertension, calls in to refill her zolpidem, immediate release 10 milligram. She takes citalopram 20 milligram, amitriptyline 10 milligram, and mirtazapine 15 milligram. She says that she's worried so much about her lowly daughter, who works as a lab tech in one of the hospitals full of COVID-19. Patient says, of course, she says she's critically needs her zolpidem. What are you going to do? Are you gonna prescribe it or no? Just show in the chat, are you going to prescribe it? Anyone will give this lady her zolpidem? Pharmacist says no. So obviously she's confusing things. Obviously she's confused here, this patient. I mean, why she's taking zolpidem? She said that she's worried, not that she's saying I can't sleep. She's worried about her daughter. And Manal, is the picture and everything is clear? We're almost like 10 minutes and then we will finish. Again, going to this patient, this patient obviously has multiple medications, putting her at risk of side effects. And this is the recipe of having the maximal side effects given this. Look, SSRIs, amitriptyline, mirtazapine, and zolpidem. This is not really great combination. So definitely, personally, I wouldn't really refill it. I will have to carefully assess this patient to give zolpidem or not. Definitely, she has well-justified worry here about her daughter, lonely daughter. She's working in a hospital full of COVID-19, but also I'm concerned about her to give zolpidem when she's taking all these medicines. If I can even bring her safely to have a face-to-face interview and put clear guideline on how to manage her worries, manage her symptoms, and manage the use of zolpidem, and put like clear expectations, I would do that rather than just go ahead and refill the zolpidem right away from the clinic. Now, this is the last table that I'm going to show you. Is it clear? Do you see this table that I'm presenting to you? Is it clear? Now, this table that if you look at, these are the benzodiazepines that are indicated or for insomnia, and the Z drugs and the other drugs. So this slide is important. You can take a picture of it, but this is the slide that if you go to your practice and you want to, or you see a patient taking any benzodiazepine that is not of those, or any sleeping pills that is not of those, then it's indication for you to go ahead and review the practice and review the patient carefully and make sure that there is like a clear indication and a clear documentation of why this patient was put on a medicine that is not from this FDA approved table. Now, the last thing I want to say, I'm going to give you this tip For your refill clinic, please, these are the caveats for your refill medication clinic. Whenever you have this slides and the presentation will be in our website actually after the presentation. So you can go there and you download it, and you'll download extra material from www.saudiedublood.org. We will make it available. Now, this is the last slide, and I'm going to just share with you these caveats. First of all, when you refill a medicine, make sure that you know the indication. Second thing, make sure that the effective dose has been determined, that the expectations, both from the side of the doctor and the patient, has been there, and the plan of discontinuation is documented too. Do not be directed to drug therapy, especially in insomnia, because drug therapy for insomnia is not the first line treatment. It's actually second line. The first line is non-drug therapy. Cognitive behavioral therapy, relaxation techniques, stimulus control, cognitive restructuring, all of that, but never drug therapy.